welcome to Conversations with. I'm Courtney.
And I'm Keith.
And we're the clinical team here at Burtons Academy. With our combined passion for monitoring and ventilation, we're here to rewind and remind you on the foundations and principles used to form the knowledge and understanding in everyday anaesthesia. And following on from last week's episode where we talked about how CO2 is formed way down at the tissue level and then it gets into the blood, in this week's episode, we are talking about how the CO2 gets from the blood to the lungs and then from the lungs out to the environment or out to our kind of CO2 monitoring equipment, so our capnograph. I am joined by Keith, so good morning, Keith.
Good morning, Courtney.
And I know that you're going to be very excited about this topic because I think you have been this whole season, as have I. And you said something last week in conversation, and I wrote it down actually because I thought, oh, it's so profound. You were talking a lot about monitoring. You know, it's not an art, it's a science. And I thought, oh, we're going to put the science to this whole, and I put in quotation mark, art of capnography. It is just science. We can break it down and start talking about equations and put, I guess, meaning to a lot of things we read in textbooks that ultimately gives us the reading that we're charting on our everyday anaesthetic record.
Exactly, Courtney. I think the whole point of these podcasts is to talk about what we see and relate it to what physiology we know. And the physiology is the science for the most part. I mean, there's still so much I think we don't know about what goes on, but we know a lot more than we did. So we can relate now what we see in practice to what actually we understand as physiology. And the whole point of these podcasts and our conversations is to bring those two together, because we may later talk about some sort of equations and you think, oh, equations, I don't need to know equations. And no, you don't, but it's quite helpful to know that they exist and how they explain the things that we see.
Yeah, absolutely. Bit of groundwork, bit of foundation building, isn't it? Yeah,
and I'm hot on foundations. I think, anything I do, you've got to have a foundation and then you build on it, When I design something or write some code, I get my foundations right. I get the core bit working, and then anything I do from that just builds on those foundations and is getting it right that's important. So I think we need to get the foundations right, and I think we've gone a long way on this journey. And I was reflecting over the last few podcasts, and we talked about oxygen and CO2, and I just still amazed by the influence of CO2 in the body. Oxygen would seem to be very important. If you ask which is the most important molecule, oxygen or CO2, as far as mammals concerned, you think oxygen. Can't do without oxygen.
That's definitely my thing. I would be like, well, we need oxygen to live, but actually it's CO2 that could also kill us.
Yeah, and look at what that CO2 does, and we covered it last week. It's just amazing effects all over the body. Has so many influences on so many processes that oxygen just sort of fades into the background, really. So we got, I think the last podcast we arrived at the pulmonary capillary. We'd got the CO2 into the red blood cell, into the hemoglobin. So we got carboxyhemoglobin, and we were ready to go on that journey now through the rest of the body and back to the lungs and then thence out. So we're just going to carry on with that journey, I think. And I like to bring up my analogy again of the tube train. So the reason I like the analogy of the tube train is you've got defined periods when people can get on and off. You can only get on and off at a station, and in between stations down that tube line, you're stuck in that effective vessel. And I think that's just analogous to being a red blood cell being stuck in a arterial vessel, capillary vessel. It can't get out, or a venous vessel. It can't get out, whether we're going from the lungs or to the lungs. So between the tissue and the lungs and the tissue, we're in this sealed compartment of a train, and only when we get to destination that we can actually things can change. So we've got onto our CO2 is now on our red blood cell. It's dissolved in the plasma. We've got most of it in the plasma, that buffering system, that bicarbonate buffering system. A little bit dissolved, but not much. And then, 20-25% is, or less than 20% is in the red blood cell. So off we go. So that red blood cell now is in the compartment. It can't get off. It's going through those venules to the veins, back to the right side of the heart, then up to the lungs and then down to the pulmonary capillaries, and that's where it then gets to a station, in the sense that we get to a point where the doors can open and the CO2 can get out, and people can get in, oxygen can get in. And then we have this effect, which I think we've talked about before, the Haldane effect, which is where the propensity, the affinity for oxygen by hemoglobin is affected by its environment. Yeah. So, and the affinity for CO2 is affected by the environment. And this Haldane effect basically says, in that environment now, which is relatively richer in oxygen, it's going to let go of its CO2 and let that CO2 go. So now CO2 is released back into solution and diffuses across the blood gas barrier and into the alveolus. Once in the alveolus, then we're on our way to being breathed out. So we have that Haldane effect there, which we discussed last time. So I'm not going to go into the full detail of it, but it's a nice snap action. I was thinking, do you remember as a child we had those little toys at school? I had them at school. You would click them. They were like metal things, and you click and they'd click into one position and they'd stay there. And then you push them back, they can make a loud click, and you click into another position and they would stay there. So it was kind of like what you call a bistable thing. It goes click, 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 and you make a horrible noise, and it annoyed the teachers. And it was one of those crazes where you just had those click, click things. But it's bistable, so it will be stable in either position. So this is our hemoglobin molecule really. When you click it in one position, it's stable and picks up oxygen and displaces CO2. When you click it the other way, it releases oxygen. Sorry, did I say that? One picks up oxygen and one releases oxygen. One releases CO2, one picks up CO2. So it just flips between those two. And that's the difference between the relaxed state and the tense state of the hemoglobin molecule. So we're doing this flicking in the appropriate tissues, either the lung or the body tissues. So we now just released our CO2. We picked up oxygen. We got that exchange. We've gone from our tense state holding CO2 to our relaxed state holding oxygen. Our hemoglobin is happy. CO2 is now released, and it's going to go across that barrier. I think I asked you this question before. I did ask you this question before, Courtney.
Oh, no.
So
Here we go.
In terms of ability to cross that membrane, who's got the easier ride, the oxygen or the CO2? It's all about the solubilities.
The CO2 has the easier ride.
Absolutely, yeah. By a long way.
Yeah.
It's got a solubility compared to oxygen about 20 times. That has real implications. It means that basically when you get fluid filling up in the interstitial spaces of the lung, or you've got fibrosis, or you've got any impairment, it's not going to affect CO2 anywhere near it's going to affect oxygen. So that's going to be the first thing that you're going to notice. So we can safely assume that under nearly all circumstances, once you get CO2 back to those lungs, it's going to pass nicely into the alveolus because of basically a gradient. We've got a concentration gradient. So we guess we should refresh ourselves about what that concentration gradient is and why it's formed. So we know that down in those tissues that they're heavily respiring, producing CO2. So we know that CO2 is going to be higher there than in the arterial blood that arrived to that tissue. Arterial blood is going to arrive at about 40 millimeters of mercury. And depending on what that tissue is doing, if it's fairly sessile and not doing much, it's going to leave that tissue with a partial pressure of CO2 of about 46, 48, something like that. But if it's muscle may running hard or working hard, or generally have a lot of activity in that muscle, it's going to be higher, and it could be 50, 55, depending on that. So there's no right answer. It's just going to be much more than the 40 that it came in at, because we're just removing the extra CO2. So we're going back up the lungs with something like 46 to 50 millimeters of mercury, and we're now completing the circle. Okay, and now you're going to think, okay, well, it's coming up at 46. Let's say it's coming up at 50. And it's coming up at 50, but we know that our end tidal, when everything's happy, is 40. So there's a gradient there, but isn't that 50 going to now make that 40 in the lungs go up to 50? So our end tidal should be 50. Good thinking, but I think the the bit of logic that's been missed is the volume ratio. So we're returning a small amount of CO2 relatively. We're going to dump maybe, let's say, 20 mils of CO2 into the lung per heartbeat, depending on the size of the animal. Let's just take a figure of 20 mils, but we're dumping it into a lung, which is, we talk about an FRC now. We've got that residual capacity. We have to consider that. So it's dropping that 20 mils of CO2 into something which is a volume of something like 500 mils to a litre.
Mm.
So even though it's higher, it's only going to change the actual value in the lung, in the FRC content, by a relatively small amount. So it may have all been 40, and the lungs would have all been 40. We've got 1 litre of FRC in a Labrador, and we're going to get to the lungs, drop off that CO2, maybe drop off 50, 60 mils of CO2. And I'm just plucking numbers out of the air here for indication, but that's going to be 50, 60 mils into a tidal volume, or reservoir, a reservoir of 1 litre. So it's like my analogy before of a teaspoon of boiling water into a cup of, or a saucepan of warm water. It's going to change it slightly, but it's not going to change it massively. So it diffuses down the gradient. The blood equilibrates with the FRC content of CO2 in the lungs. So the blood leaving the lungs is going to be more or less 40, where the lungs have stayed all the time. So the huge FRC, which we introduced in previous podcasts, is a stabilizing agent. Now it's really acting as a buffer to that CO2, so that when the CO2 value comes back to the lung, and the CO2 gas comes back to the lung, it doesn't change the value that's in the FRC much at all. So we've got a really nice system now that's staying pretty much stable. So we've then got 40 millimeters throughout the whole of the FRC. The animal breathes out, and that's what we see coming up the airways, coming up the trachea, and that's what we see on our cat. So that's why it stays at 40, even though the pressure in the blood returning to the lungs is higher at 46, 50, 55, whatever, depending on how much CO2 is being produced.
I mean, otherwise it would be a big wave, wasn't it? I used to think that the blood going back to the lungs, if you arrive at the lungs with this, I don't know, bucket of CO2 and you just throw it all out, and then you start back at zero as you go back around the arterial circulation. But really, that would just cause our body to be in this constant huge wave up, huge wave down of CO2 levels. But that just keeps it nice and constant, really, doesn't it? Like,
exactly. So
not such a wild ride.
Yeah, I was saying, if you didn't have the FRC buffering effect, then basically it would come, your every time a heartbeat came to the lung, you see a spike in the CO2, and so depending on when you breathed out relative to a breath, you'd get different levels of CO2. It wouldn't be smoothed out at all. It would just be a succession of peaks and troughs that would be noticeable. So the FRC just smooths all those out. I don't suppose there's many electronics engineers listening, but this is basically what a smoothing rectifier, or a rectifier smoothing capacitor, does to a mains power supply. You get the peaks and troughs of AC converted to DC. So you've got lots of troughs now which are DC, but there are lots of peaks and troughs. Then you've got a capacitor on it. Capacitor smooths it out, gives you a flat line as DC. That's exactly what's going on. They're completely analogous. And again, I can't remember. One of your friends, Courtney, I think, into LT Spice. Remember I mentioned LT Spice before, the computer simulation program for electronics engineers. Okay. It's like I'm going off
band.
Well, it should be, shouldn't it? Really?
Is it a pop band?
There's a program called LT Spice. I'm just going to talk about this very briefly because it's quite interesting. LT Spice is a computer simulation program for electronics engineers. And I often go to LT Spice and I will model lung behavior and circuit behavior in electronics, because the two are absolutely parallel. So I'll make a lung as a capacitor, and I'll make a delivery of gas to the lung as what's called a constant current supply, and I'll feed a constant amount of CO2 to that capacitor, and then I chop it up and send it in little bits and see the waveforms that come out. The waveforms that come out exactly represent what we see in terms of our breathing. So they're so analogous what's going on here. And okay, what I'm saying in a long-winded way is that in nature, what we're doing to smooth out those variations in CO2 is exactly what we do in electronics to smooth out variations in power supply noise. Get rid of it, make it steady by having a big capacitance, and the lung is our capacitance. So we can have a whole podcast on healthy spice if you like. It's just
yeah. What is it? It's a science. It's not art. It's science.
Exactly. So I hope that's kind of reinforced the function of the FRC. Now we've got that CO2 in the lungs, it does ask some questions about what does it do there? Does it have an effect? If there's lots of CO2 coming back, does it displace the oxygen that's in there? Can you have lots of CO2 and lots of oxygen at the same time? Probably not something people really think about a lot, but I want to drag your mind back, Courtney, to something you may have come across before, the alveolar ventilation equation. Does that mean anything to you?
Yes, it does. My blood pressure's risen as well. It's probably got some vasopressor effects for me, just those words.
So what can you remember from the alveolar ventilation equation?
So the ventilation equation, not the gas equation.
The ventilation equation, exactly.
Okay. I remember that the way that you ventilate has to be in direct relation to how much CO2 you have in your body. So if you change the way you ventilate, if you increase ventilation, your CO2 must drop. Is that right? And then when you decrease your ventilation, your CO2 will raise. And that's how we get hyper and hypocapnia following hyper or hypoventilation. But there's a mathematical equation for that, isn't there? Or a bit of, I don't know, is it really algebra when we just use lots of letters? I don't really know.
It is a form of algebra. Yeah, we're using letters to represent or symbols to represent variables that we're talking about. Yeah, exactly.
Yeah.
So the alveolar ventilation equation basically says that the CO2 content equals a constant, and it doesn't matter what that constant is, divided by the alveolar ventilation rate. The only thing to take out of that is that the ventilation rate is inversely proportional to the CO2. Or if you want to think it the other way around, the CO2 is inversely proportional to ventilation rate. And it's really alveolar ventilation rate. We have to separate the true alveolar ventilation as the exchange volume as opposed to the tidal volume, which includes the dead space. So just being a bit pedantic, we just want to think about the alveolar ventilation rate. It's nothing to do with the dead space. So we're talking about tidal volume minus dead space. But then, the alveolar ventilation rate is directly linked to the CO2 value in the lungs. Assuming we've got that constant production of CO2 in the body and it's coming back at a constant rate by the heart, those two being equal, which it normally is in our patient during the simple anaesthesia, then what we could say is if we were ventilating and we doubled the alveolar ventilation rate, we must halve the CO2, the end total CO2. So if you had an end total CO2 of 48 and you doubled the alveolar ventilation rate by increasing doubling the frequency of breaths, shall we say, double the alveolar ventilation rate, then that would halve your end total CO2 to 24. It has to. Mm-hmm. And that is the beauty of bringing the math and the physiology to practice, so that when you've got that high end total CO2 and you want to bring it down, you know that if you increase the alveolar ventilation rate, you'll bring it down. Now, we can't measure the alveolar ventilation rate, but what we really know is we've got tidal volume and respiratory rate. Now, if you change the tidal volume, because the dead space is not a perfect relationship, so if you double tidal volume, you don't necessarily double the alveolar volume. But if you double respiratory rate, you double the alveolar ventilation rate, because the alveolar volume stays the same and you've just increased it. So that's why I like to often teach people to start with respiratory rate to control minute volume rather than tidal volume, because it does relate directly to alveolar volume as well. So that alveolar ventilation equation sounds scary, but it boils down to that fact that if we double the ventilation rate, double the respiratory rate, we will halve our own total CO2. And I think from what we've said in the last couple of podcasts, this is all about keeping CO2 at that magic 40 millimeters of mercury in the blood. And we do that by assessing it as being 40 millimeters of mercury in the expired breath. And we now know if we stray from that 40 millimeters of mercury, all those repercussive effects, the effects on heart muscle, the effects on enzymes, the effects on respiratory centers, all the things we talked about last week, all affected by that. So that's why we use capnography to keep our own total CO2 at 40. And then we need to talk about another equation. Do you remember the alveolar gas equation?
This one, I mean, when you write the two on paper, when you put this alveolar ventilation equation and then the alveolar gas equation, the ventilation equation is just I don't know, what is it, 5 letters really, 5 or 6 little letters. And it's all it's nice and it's small. But for me, for years, I've been talking about hypocapnia from hyperventilation and did not know it was actually part of an equation. Now, when you ask me about the alveolar gas equation, when you see that written on a piece of paper, you think, what is it? It is, I don't know how long it is. It's about long as the alphabet
2.5
is,
inches long.
Yeah. If I look at my piece of paper, if I dig up my study notes, I think, well, that goes across the whole top line. But to me, I love that equation. I love breaking it down and having a look at different things because I feel quite happy that I'm like, oh, I know what FiO2 means. I know what this means. And I feel quite good about it. But I do, yeah, it does mean something to me now after I have read it quite a few times. And that's just, well, it's able to tell me what the level of CO2 is in the alveoli. And then obviously, if we've got certain levels of CO2 in the alveoli, we can only have certain levels of oxygen in the alveoli.
Absolutely, yeah. And just like the previous equation, it's not necessary really to fully understand it, know how to derive it, how to write it out or anything. I just want to show how something which, appears esoteric and difficult is actually very, very useful.
Yeah.
So what the alveolar gas equation says is that the oxygen concentration in the lungs, the PaO2, so the oxygen concentration in the lungs, is derived from or affected by the inspired oxygen fraction, and the amount that actually gets there depends a little bit on saturated water vapor pressure. So but relative really to atmospheric pressure, and then we have to subtract the amount of concentration of CO2 in the lungs, and just modify that a little bit depending on whether they're metabolizing sugars exclusively or fats. So that respiratory quotient we talked about as well. So it boils down to the fact that really we're looking at the PaO2 in the lungs depends on the inspired fraction and the amount of CO2. Okay? And that's basically it. In other words, if you've got a high inspired fraction, so when we're on 100% oxygen, so the fraction is 1 or 0.9, then the PaO2 is something like 700 and something, minus the CO2 element, which is only about 40 or 50. So the PaO2 ends up being in the 600s, loads and loads of oxygen. Okay? If within 21% oxygen, so fraction is now 0.21, our oxygen PaO2 is about 150 minus the component for CO2. Now, our CO2 could be something like 40 over 0.8, which is 50. So our PaO2 is 100. And that's the stable situation in the lung. For you and I breathing room air, we got about 100 millimeters of oxygen in the lung because of the presence of CO2. Okay, that all sounds really nice and straightforward, and it sounds like it's something that will cause no problems. But the real essence of the alveolar gas equation is that it's the PaO2 minus a bit, depending on how much we're breathing in, minus the CO2. When there's lots of oxygen, that minus the bit, depending on what we're breathing in, is massive. When you're in 21% oxygen, that bit minus that bit becomes small. Now your CO2 portion becomes much more important. So I'll go so far as to say, just to simplify it, the Alveolar gas equation in room air says that you can only have so much oxygen and so much CO2. If you put the CO2 up, you must drop the oxygen. Yeah. And if you drop the CO2, the oxygen must go up. There's got to be that balance. It's happening in 100% oxygen, but the CO2 change has so little effect to go from 700 millimeters of mercury of oxygen down to 650. You wouldn't notice it. But when you're down in 21% oxygen, a fraction of 0.21, now we're going from, so we go to 80 millimeters of mercury, our PaO2 is going to drop by, well, it's gone from 40 to 80, it's going to drop by 50. So it's gone from 100 PaO2 to 50 because the CO2 has gone up by 40 divided by 0.8, which gives us 50. CO2 has gone up by 50. So the oxygen's got to go down by 50. Now, it was 150. It's now down to 100. Okay, so now we're starting to see how the CO2 can affect the oxygen. I think we maybe alluded to this last week or in a previous podcast. So let's think about, one of these animals that's not breathing well, that's hypercapnic. Maybe it's one of these Boas dogs. They're going to be probably quite happy while they're intubated, but remove that intubation and then they're going to not get oxygen in as well. The tidal volume will be less. And now we've probably got a degree of hypoventilation. So our alveolar ventilation equation says that hypoventilation means that CO2 will go up. And our alveolar gas equation says that if the CO2 goes up in room air, our oxygen must go down. And it's absolutely true that if you had say you had a PaCO2 of 70 to 80 millimeters of mercury. Okay, there's a lot. I'm saying it's a lot, but I just want to explore this at the sort of extreme to see what happens. You have a PaCO2 of 80, then you've now got that value at the end of that equation, PaCO2 over 0.8. 80 over 0.8 is 100. And we said that the PaO2 was equal to that fraction bit, which came down to 100. So 150 minus the 100. Now we've only got a PaO2 of 50. Don't worry if people aren't following the math, don't worry. But what I'm trying to say is that because the CO2 has gone up, our PaO2 has dropped to 50. 50 is not sufficient to support normal saturation.
I feel like this lightning bolt came down on me, and it really only just made that click very recently in my mind that if I imagine my balloon, my alveoli, of course, I did actually think for some time you could have high levels of CO2 because they weren't getting the CO2 out. But of course, it has to share the space with oxygen. And that's exactly what you're explaining. But to me, I just thought, oh, okay, they must be taking little breaths. Therefore, they're just not getting the oxygen in. But it's so much more than that. It's got no space to go because there is so much CO2 way down. And the fact that it shares a space, of course, you can't have 150% of gases in a space. You can only have an area filled to so much, and they have to share that space. I think that really did dawn on me, and it made me start to think about perhaps some patients in recovery as well. But yeah, just knowing that they must share a space. So if you have high levels of CO2, those levels of oxygen have to go down. And that, for me, a huge lightning bolt moment.
Yeah, and I think one thing maybe I could have brought into the discussion and the explanation is that what I didn't say is I said 21% oxygen. Absolutely, what that I implied, and what everybody knows but may have forgotten, is that we've now got 79% nitrogen. So the nitrogen is occupying a lot of the space now, and so there's only room for a certain amount of gas. The nitrogen is not going to change because it comes in and goes out the same because it's not soluble in blood to any great degree. So we've only got that bulk of nitrogen, and let's think about it like let's put marbles in a jar, okay? Let's put green marbles at the bottom, which is our oxygen. Yeah. Then we'll put a big layer of black marbles, which is our nitrogen, and then we'll put some blue marbles at the top, which is our CO2. And at 21% oxygen, we've got a nice balance between the CO2, the oxygen, and the nitrogen. And our jar is just completely full. It's to the right height. Now we decrease our alveolar ventilation and the CO2 goes up. Yeah. So we're going to get a lot more CO2. And our jar represents 100%. We can't have more than 100%, as you've just rightly said. So now we've got a double layer of CO2 at the top, and we've got the same layer of nitrogen because that doesn't change. The only thing that can give to allow that jar to be full is some of the oxygen's got to be pushed out. So it decreases and the ratios change, and we've got a lot of CO2, same amount of nitrogen, but we must have less oxygen. That really is the Alveolar gas equation. That's what it means. And when we're in 100% oxygen, when the animal's on an anaesthetic machine, our jar is full of nearly all green because it's oxygen, and we've got a little layer of blue at the top. Doesn't matter if we change that blue, even if we double it, we've still got masses of green. Yeah. But when we take away a lot of that green and put black marbles in there with the nitrogen, we've got less of a buffer on our green. We increase our blue, it has to push out the green. That's what I'm saying. So does this have an implication? I think it does. I think if you have an animal that's hypercapnic and you take it off an anaesthetic machine and you put it into recovery, it may well be mildly hypoxic or run the risk of becoming hypoxic, particularly if its ventilation is compromised, which it is, because it's just still full of some drugs and it's still got anesthetics on board, even at a low level, but they're still there. So we've got some respiratory depression, so we've probably got some hyperventilation. Alveolar ventilation equation says that CO2 must go up. Alveolar gas equation says that the oxygen must come down. So it's a matter of degree, isn't it? But it does ask some big questions now. Wouldn't it be much more beneficial to measure the oxygen saturation of that patient in air, in that recovery, than it actually was during the whole of the procedure when it was on 100% oxygen?
I think you and I could probably have a very fun discussion around your pulse ox being a pulse counter during anesthesia when you're on that 100%, because exactly that. When someone says, "Oh, in our healthy bitch spay or whatnot, the pulse ox dropped massively randomly," and I'm thinking, okay, the pulse ox probably wobbled off and fell on the floor. And for me, I like my pulse ox in anesthesia itself because it gives me that nice heart rate. And assuming they've got nice healthy lungs, getting such a high concentration of oxygen, I'm always going to think my patient's oxygenating well. I don't need that 97, 98, 99, 100 pulse ox for me. But in recovery, without a doubt, I feel like if I could, I would walk around with a little handheld pulse ox and I would put it on every single patient in recovery. Because for me, that's exactly what you just implied. It's so important. They are still hyperventilating. First of all, they're cold. Well, often there's a degree of hypothermia. They're a little bit colder. Those muscles aren't working so well. Perhaps they're really tired from trying to breathe through a really narrow ET tube like a straw. So they've got this muscle fatigue in their respiratory muscles. Perhaps they're painful as well and they don't want to take such a deep breath. And then we still have all of those anesthetic gases, still coming out. We still have those anesthetic drugs still on board. We've still got those sedatives. We still have, our pre-med might still be a factor. And then perhaps we're even recovering them laying on one side of their chest as well, which is perhaps the side that they've always been laying on for that last half of their dental. So to me, I'm thinking, okay, that pulse ox is so useful in recovery. I'm going to use it and see if my patient's oxygenating well. And I used to think, okay, maybe they're a little bit sore and they don't want to take that deep breath in. Therefore, they're getting less oxygen in. And not once did I start to think there was a problem getting CO2 out, because I always thought, well, it's difficult to measure CO2 in the recovery period. Now I know it's not so difficult. We've got some literature that says you can take your side stream capnograph and push it snugly into the nares and you can get a reading. You could get a trend from that. But for me, the pulse ox, that's a recovery tool for me now.
Absolutely, yeah, it is. And one of the things I want to pick up on that, we talked about fatigue, and I think we did kind of mention fatigue in a previous podcast about its effect. And you said, yeah, trying to breathe out through a small tube would, increase their effort, which it definitely would. And this roadshow that you and I have been doing, Courtney, at these different venues, I think one of the things that we've tried to impress upon people is how much we affect patients' compliance during positioning. So if you put an animal on its back and restrict it, you restrict its thoracic compliance, particularly if you put a wedge down both sides of its chest and some sandbags to hold it in place. And then, the animal's spontaneously breathing. It's actually got to work quite hard against that reduced compliance that you've imposed on it. In other words, in more layman's terms, it has to push out against those restrictions that you put there to get a decent breath. So we're going to have fatigue from that. So you may have had a long period of the animal breathing against that imposed restriction, and they are fatigued. They do have respiratory weakness and tiredness, and then we put them in a cage, and they're massively reduced amount of oxygen in their inspired breath, and all these, as we said, per these equations, this leads to hypoxemia, a hypoxic, mixture in the lungs, and a resultant hypoxemia and a hypercapnia, and that they're now more vulnerable, I think, than they were ever on that table.
And that's right when we take all the equipment off.
Exactly.
They leave that theatre, we take it all off, and then we put them in recovery, perhaps don't look at them so frequently, and that's when they're really struggling.
Yeah. So what can we practically do about it? Because life is life, and it's busy. You've got 7 or 8 ops to do that morning, and your consultation is just overrun by half an hour, so you're in a rush. So you're going to plow through them. You're going to do your bitch spays, put those in the cage. You're going to do your dentals last or whatever. But what can you do? Well, I think you have to make some time. You have to observe these animals. I know it's busy. I remember in my relatively early career, I've been qualified maybe, 7 or 8 years, and doing a row of nutrients in the morning. You got 3 cat spays to do, a couple of bitch spays. You got a pigeon that someone's brought in, and you've got a relatively long list. And I did these 3 black cat spays. I remember them being black. The practice I was working in, we used to put them on the floor near the radiator in sight of us, before the tube was taken out, so we could keep an eye on them. And I lost a cat because the cat died and we didn't notice. I asked the nurse to just check the tube on the cat, and she said it's easy to take out. And I said, well, is it okay? And she said, actually, no, it's not. And it wasn't at all. It had died. And from that point on, I made it a point that even though it was a routine procedure, those animals should be checked routinely, repeatedly. And actually, it spurred me to make a little device. I made a device. It was a little band that went around the chest based on a piezoelectric principle. So it was a bit of wire, piezoelectric wire, and every time the chest moved, it would reset a signal in the little circuit I had. So there was no noise. If the patient didn't breathe, then that reset didn't happen. So the alarm went off. So I put these on these cats afterwards. It was only a little thing I made, but it made me feel happy because I knew if they stopped breathing, it'd go beep, beep, beep. And that began some of my interest in post-op monitoring, because I think post-op monitoring is woefully underused, and it's the time when they really need it. So I digressed a little bit, but I think it's really important that we do monitor them, and they need time. And if you're busy, it's not an excuse, because they'll die whether you're busy or not.
Yeah, and we know that they die. We have literature to say they're more likely to die in this period if they're going to have an anesthetic complication. Like, we literally have hundreds of thousands of animals that have had their data captured, and we know that they die in the recovery period, and they die from cardiovascular compromise, so perhaps ongoing bleeding or hypotension or drugs, but respiratory problems. They 100% down to 21, no monitoring on them. And it does get me these, I'm not going to say these people, some people who say, oh, there's, I don't trust the equipment. There's no better monitoring equipment than my eyes and hands. And I'm thinking that's okay. But without a pulse ox, if you flip the lip, that change of their mucous membrane color is not happening for quite some time. They're not going to become hypoxemic visually. You can't tell until it's like 85-ish%. And by then, have you also got, is the light in the room changing the way those mucous membrane colors look to you? So for me, just get it, put it on the tongue, and then you can walk or put it on the prepuce, on the vulva, or the toe webbing, on the ear.
Mm,
And then you can kind of turn your back for 5, 10 seconds, start filling in their hospital chart, and you can still hear that nice beep, beep, beep. And we know exactly when our pulse ox is changing because it goes beep, 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 beep. And
yeah,
you hear that
absolutely. Change
tone.
in tone. Yeah.
Yeah, yeah. And actually, just speaking a little bit more about that, the literature, that SEPSAF study that says, when our patients actually die, patients that have a pulse ox are more likely to survive. So, you know,
Yes.
it's all written there.
Yeah, and I think we've got an unusual situation. I think we're probably a forgotten entity in the sense that the medical world is huge, and they use pulse ox a lot, but we have to remember that they're using oxygen levels far lower than we are. They are in many instances using it at 30 to 35%. And in those instances, hypoventilation will lead to a change in the oxygen because of the alveolar gas equation. That will be indicated by your pulse ox. So it's an early warning system for them, way more than it is for us. So we're
Because we
kind of
always just put them on 100.
with 100, then we lose that ability to see what's going on. It won't reflect what's going on. I mean, yeah, it means that basically they're never going to be really hypoxic from the point of view of what oxygen is being delivered. They may be hypoxic because they're just not breathing, or there may be poor circulation, there may be a massive shunt. There could be all sorts of reasons why they subsequently become hypoxic, but we avoid that immediately by going to 100%. I suppose it's a convenience factor, isn't it? Yeah, it's easier to buy a bottle of 100% oxygen than it is to buy a bottle of 35% oxygen. I don't know how you do it. You have to have a blender maybe, and it just adds complexity. So we've drifted into this situation where we're given 100% oxygen, which I think is not necessarily a bad thing, but we have to be aware of what happens when we come from that 100% back to 21, and that's our danger period. Um, yeah, and I think going back to my cat that died, the little cat spay, didn't do a post mortem or anything, but my feeling is that one was probably a blocked ET tube, compromised ET tube. Basically, it was a very healthy cat. Like, it could have been all sorts of things, but that's my feeling, was that basically it was an unobserved hypoventilation, couldn't breathe, mucus bled, blocked tube, and basically the breathing just stopped, and then we lost it. So it happened, and I think from that point I'm very, very hot on post-op monitoring.
Mm.
Okay, so we become a little bit morbid there.
Oh, I'm
But
sitting here doing my sad face.
yeah,
Oh, it's so devastating when it was. I mean, we all learned from it, and everybody listening will appreciate that we learn from our mistakes, and perhaps some people will take our comment on board just now about not to neglect that period of
yeah,
the anesthesia experience. Yeah.
never easy losing a patient.
No, no.
But I think, like most people in practice, I can remember all the patients that I lost,
Yeah.
because it has a big effect on you, and you learn, and I guess what's always at the back of my mind is that I'm sure the doctors do the same thing. They lose patients, they must do.
Yeah.
They must do, and it must be quite difficult for them to take that on board as well.
Yeah.
Anyway, so here we are, where we've got back to where our lungs are full of CO2, where we understand that the 21% is a very different situation to the 100%. We should really be monitoring them. If we can do continuous pulse ox, that's brilliant. Even periodic will be better than nothing. But then that begs the question, what do we do? So if you've got this animal that's got this compromised breathing and it has got high end tidal, and you're worried about its state of oxygenation, what can we do?
Well, for me as a nurse, there's just a few quick things I'm going to do, just to see if that makes a change before I do what I know you want me to say, which is I know what's coming. So as a nurse, I'm looking at my patient, put the pulse ox on. Okay, it's a little bit low now. Perhaps I put my capnography up their nose as well, and I'm sensing, okay, there's a high CO2. Therefore, I know there's going to be a slightly low oxygen in the alveoli, or I've looked at my pulse ox particularly. First things I'm going to do is obviously sit them up, put them into sternal, extend their head and neck forward, put something under their head, make sure that they can get the oxygen in. I'm also going to be trying to actively warm them. And I'm probably not so far running to the veterinary surgeon and saying, gosh, I think we need to antagonize some of these respiratory depressant drugs. But I'm definitely positioning my patient better and warming them up so that they can move their lungs and the passage to get that oxygen in is better. But then, to be honest, I'm probably just going to pop a T piece on or a bait on the breathing system, and I'm just going to start giving them a bit of support, just a bit of flow by.
Yeah, because that's the practical things that we can do. In other
Yeah.
words, we're just going to, augment that oxygen,
Yeah,
change the
give them
balance,
that bit more.
put more green marbles in our jar, basically.
Yeah. Yeah.
Yeah.
Oh, I love that analogy so much. But that's exactly it. If I've got a patient laying laterally and they're curled up and their head's tucked around, I still want to make sure that they're nice and straight and upright to receive that, those more green marbles that I'm going to give them. So for me, supporting them with a bit more of an oxygen therapy. And once you start looking at your patient's oxygen saturation and recovery, I do think you'll start to notice a few of them trending down. And one thing I used to do is put the breathing system in front of them, watch that pulse ox come up, take the breathing system away, watch that pulse ox go down. I'm thinking, gosh, they truly right in front of me need my help. But I'm still alerting my veterinary surgeon about it. I'm still saying, I think he's having a little bit of difficult time oxygenating. And I tell you, once you highlight that to any vet I've ever worked with, it's like, okay, you spend some time with them. Let's just have 5 or 10 minutes before we rush into the next procedure. Let's spend some time with that patient. Let's make sure they can saturate. Let's get them upright. Let's give them that flow by. And even if our patients are shivering as well, a shivering patient uses quite a lot of oxygen. That's very metabolically expensive. If I have a shivering patient in recovery, not only do I know that they're probably hyperventilating, they're not using a lot of that oxygen as fuel to move those muscles. So once again, a shivering patient, I'm giving flow by to, as well as trying to warm them.
Exactly. So that supplemental oxygen is a big requirement or something we should be looking to do. Now, remind me, Courtney, because I forget what's podcast and what's blog. Have we done a podcast about oxygen cages?
I think we might have briefly only discussed it.
Okay,
We've done a very good in-depth blog, in-depth article about it.
Yeah, but not a podcast as such.
No, not a podcast as such.
No. So I know this is all about CO2, but we just really just talk a bit about oxygen because we need it to combat the CO2 problem. You think, okay, well, why don't we always give them oxygen and form an ideal oxygen cage for these patients that we're worried about? And I just want to make people aware of the amount of oxygen you need to give to a standard cage to make a difference. And just going back to my findings or our findings when we did a little survey, if you put 2 liters a minute of oxygen into your cage, then realistically, forget it. It's going to take you something of the order of nearly 2 hours to get that to go from 21% up to anywhere near 40-45%. You need 10 liters a minute, and you need at least 10 liters a minute. And even then, it's going to take you, I think, 20 odd minutes to get to sort of 50% and nearly 50 minutes to get to 100%. The exact figures I forget, but it was of that order. But if you're opening the cage every 5 minutes to check the pulse saturation, it's absolutely, even if putting it 10 liters a minute, it's absolutely no benefit whatsoever, because as soon as you open that door, and I'm assuming this is a front opening door, you lose all that oxygen. So you might think the answer to your problem is to put them in oxygen cages and always pump oxygen in, but in reality, you have to put such a lot in that you have to leave them for a certain amount of time that you're never going to give them enough oxygen. So you want to give supplemental oxygen. Don't do it by cage. Do it by flow by.
Flow by or mask for me.
Yeah, mask. So you're actually putting it there. I mean, if you've got the capacity and ability to use nasal prongs and things, then the patient will tolerate it fine. But I think that's more ICU than recovery.
Mm-hmm. Then the everyday recovery patient, yeah.
Everyday recovery patient, just a mask just works so well. So it's going to put things up, inspired oxygen to at least 40-50%. There's a limit of about how much it will do, because there'll always be the dilution with room air as they breathe in. They're just going to they'll never get all the oxygen they want from the fresh gas flow, so they'll pull it in from room air, so it'll always dilute it, but it will increase it markedly. So we can do something about it by using an oxygen mask.
Mm-hmm.
So we've now got an animal breathing out CO2, and we understand how that's been arrived at, where it's come from the tissues, up through the heart, to the lungs, into the FRC, breathe out, and just remove a small portion of the FRC. So the Alveolar FRC is 1 litre, 1.2 litres, and it breathes out 300 mils. So we're just taking a little scoop of it every time, and that gives us a means of looking at the status of the body if we measure that CO2. And we use the end tidal because that represents as close as we can get to the alveolar concentration. Because if you think about it, when the FRC starts to compress them and goes from 1.2 litres down to 1 litre in the dog, it's going to push that rich CO2 mixture up through all those alveolar ducts into the bronchioles, bronchus, and then push out the dead space gas. And then we're going to see alveolar gas at the capnograph.
Mm-hmm.
That's going to give us that classic waveform. So just to relate the two, as we start to breathe out, we've just breathed in, so our dead space is full of 0% CO2. Yeah, either we're in room air, breathing spontaneously, or we're on an anaesthetic circuit and we've got proper setup of that circuit. So when we breathe in, there's fresh gas in our dead space. We start to breathe out with all that. We want to now get rid of some of that CO2 that's come back. All that fresh gas is going to go past the analyzer, but it's side stream or mainstream, and it's going to appear as 0. And then as those alveoli start to empty and start to fill up the bronchioles and the bronchus and the trachea, we then start to see the CO2. And it rises pretty quickly because once we start to see CO2, dead space gas is gone. That's our phase 2. Boom, up it goes, straight up. Then it goes up to the level that's more or less in the FRC, because now we've got full FRC gas appearing in our end of our ET tube at the top of the trachea. So now we've got more or less full amounts of CO2. But it does notice, you notice people know you've got this phase 3 and it rises slightly. A couple of reasons why it rises, but one of the reasons is we don't have perfect emptying of the alveoli. They don't all empty at the same time. So the late ones are going to have a later contribution to the CO2. That's all. So you get this slight rise going up. Slight rise, and then the animal starts to breathe in, and as we said, we then bring in fresh gas past that CO2. So the dead space that was in the high CO2 level was in the dead space and was seen by the capnograph, will then suddenly disappear as the fresh gas moves past that sensor and starts to fill the lungs. So it goes drop, which is phase 0. And we call end tidal CO2 that highest point at the end of phase 3, because it that closely, or as closely as we can get, represents what's going on in the lungs. So we got that waveform, and our end tidal CO2 tells us what's in the lungs. So now we know from our capnograph, excuse me, that we've got an end tidal CO2 of 40 millimeters of mercury. And now, to put everything we talked about in context, that means we've got a arterial concentration of, we've got an end tidal CO2, we've got an alveolar FRC value of 40. We've got a arterial concentration of 40. That means that our pH must be 7.40, all other things being equal. And then that's the level of CO2 that then goes off in the arterial circulation. So our capnograph is telling us by its end tidal CO2 value how much CO2 is in the lungs and how much CO2 is in the arterial blood. So we've got a surrogate now for doing a blood gas. Instead of having to do a blood gas, take an arterial sample and all the little problems involved with doing that. I've got a surrogate now. End tidal CO2 is pretty much our arterial CO2.
And that's super quick, isn't it? Like, it's
breath to breath, absolutely.
Non-invasive, it's quick. I mean, if anyone's taken a blood gas sample, it takes a wee while to get it, and then you've got it, and you're frantically running off to the analyzer, hoping there's not a clot in it, or that, you've got some cassettes to run the blood gas, but you literally, with your capnograph, you get this like breath by breath, real time, non-invasive reading
Yeah.
And I used to think that CO2 was, monitoring capnography was, oh, is the patient taking a breath? Oh, they're not taking a breath. Better give them a breath. And then the more I've learned, the more you start working backwards. Okay, if that's what they've breathed out, that must be what was in their lungs. If that's what was in their lungs, must be what was in their blood. If the pH of their blood is normal, then the cells can do their functions. Actually, when we're chanting this number so benignly, going 42, I'm thinking, oh no, we're way down at the cellular levels. Like the cells can do their little functions. Hooray! There's so much more to it, I think, than just is the patient taking a breath? Oh, they're not. They are. You're literally making sure that the pH of the blood is normal by doing that, and the cells can do their thing.
Yeah, exactly. Because nature's come up with this mechanism to keep the pH of blood at 7.4 or thereabouts. I mean, it does vary throughout the body. It's not 7.4 everywhere. It's 7.35 in muscle, shall we say, and it's 7.45 somewhere else, or 7.42. Yeah, it's not homogeneous 7.4, but overall, it's 7.4, and it's done that by keeping its CO2 in its FRC and thereby expired at 40. And that's what we mess up when we anesthetize them. We mess it up because we take away that respiratory control. The medulla is suppressed. Respiration is reduced. The drive is reduced. They become animals that hypoventilate. And if we start ventilating, then we take over that, and we should assume that responsibility. And having assumed that responsibility, we then must be the body's homeostasis mechanism and keep that end tidal CO2 at 40. And I hope that throughout all of these 4 podcasts or 5 podcasts on oxygen and CO2, that it now becomes clear that that little number, 40, has such an big impact back in the whole of the body's systems. But if we keep it at 40, then pretty much everything would be okay, certainly in terms of respiratory function. And that's what we're looking at. We're looking at ventilation function and maintaining adequate ventilation. So that's why our end tidal CO2 is so important, and it's so easy to use, as you rightly said. Yeah.
You can use it everywhere.
Yeah. And now I think that leads us on to just another little subject, which I think really deserves a whole podcast, and that's to talk about acid base. We haven't really talked about it. We hinted at it by looking at or suggesting that the pH value changes with CO2 levels, but we haven't really explained why, and we haven't really explained the consequences of that changing, and then we haven't really explained at all how we would deal with it and how you would correct it. So we're really talking about acid-base disturbances. At the moment, because we've been talking about ventilation, we're talking about respiratory acidosis or respiratory alkalosis. But you can't change the state of the body without it responding. So if you have a respiratory acidosis, you're going to get a response in that body at some level, and it may be a slow response, but there will be a response to counteract that acidosis. And if you have an alkalosis from a respiratory cause, then you're going to have some changes in the body that can act to counteract that alkalosis. And I think that's something that we probably need to talk about in more depth, just to complete this whole circle of oxygen, CO2, and the impact of CO2 on the body. How much do you remember about acid base, Courtney? We're gonna have to dig deep into our brains, I think, for this one.
We will have to dig deep into our brains. I think knowing that, I feel like with our podcasts, we defunk a lot of really scary concepts to being something that we can apply every single day. And I think if we perhaps save our last podcast of this series to talk about blood gas, I don't think people should be scared to listen to it, as I probably would have thought, oh, I can't listen to anything on blood gas because it's just so complicated. There's hydrogen ions, and I don't remember much of that in my uni study, but I think we could probably talk about it and break it down really, really practically.
Yeah, I think so. And yeah, it is like any of these concepts, really. And I hope someday I can listen to a podcast that will explain kidney function to me in the same way, because I need to get on top of that one. But
Yeah.
that aside, if I can talk about acidosis in the next one and acid base, then I think we could probably bring that down That's not what I mean to say. We can express it at a level where it begins to make sense. Well, let's take away the sort of the high-powered equations. They're important, but they're not what you need to know every day. You need to know the consequence of those equations, what they mean and what they represent, hopefully like what we've done today. So what we're going to talk about next time then, we're going to talk about respiratory acidosis, we're going to talk about respiratory alkalosis, we're going to talk about metabolic acidosis, metabolic alkalosis, because those four disturbances are so interrelated. We can have a little look at things like anion gap. I guess that scares people. What does that anion gap mean? Honestly, it's a really simple concept. And once you get it, you think, oh, why didn't I understand that? So we can talk about anion gap. We can then maybe we can look at some examples of blood gas values and just kind of begin to tease out what they mean. And I think we can just have 3/4 of an hour talking about acid-base disturbances at an initial level, and I think people will go away hopefully with a grounding of what acid base is about. And it's no more complicated than understanding end-tidal CO2. So I look forward to that because it's something I enjoy. So we'll just go away, formulate our thoughts, and we'll come back in the next episode and talk about acid base. But
Sounds good.
This morning, Courtney, thank you for that. I think it was an interesting passage from
It was
tissue
very
to the
fun.
lungs. Yeah. And
Definitely.
be back soon.
Yeah, talk to you soon.
Okay, bye now.
Bye-bye. Thanks for listening to this week's podcast. Don't forget to follow our podcast to stay up to date with the latest episode, and feel free to share with your team. If you have any questions or feedback for us, or simply want to know more about what you've just heard, please send us an email to clinicalsupport@burtons.uk.com. Catch you next time.